could be like some pitfalls and tricks in MSK. So just want to ask you, raise your hands, those who are dealing with traumatic knee injury on a daily basis. What my father is. And when I was searching for the dark side of the moon, which I consider is dark side of the knee, is a posterolateral corner. I got this picture in Google Images, sorry. And the key problem is that the anatomy of posterolateral corner of the knee was once thought to be perplexing and esoteric. And that's why we have a varying nomenclature of anatomy of this region. And this adds some unnecessary complexity. So, facts that posterolateral corner structures are resisting external and varus rotation of the tibia, first of all. Second thing, that isolated injuries of this anatomic ACL or ACL tear also should take in consideration and manage the posterolateral corner of the knee. So mechanism of the blow, main mechanism is a blow to anteromedial part of the knee or varus blow to the flexed knee. Also, as previous lecture told, there are several clinical tests which also they have it in the knee surgery, and I won't stop on them, but there is a Huxton classification which is based on the instability and the varus stress forces of the knee in the full extension. And the traumatologists, they have the 3 grades, grade 1, grade 2, grade 3. They isolated means that there is no cruciate ligament tears, so only posterolateral corners. These traumatic injuries will be managed non-surgically. All others, grade 2 combined injuries and grade 3, which are correlated with the full thickness tear of the structures, will need surgery. Of plane on your MRI scans. The second thing that PLC structures are close to each other and can sometimes overlap. And there are several various anatomic variants of this anatomical area. So, first of all, I want to pay your attention that PLC injuries should be mentioned in all the cases, because if they won't be mentioned, the cruciate ligament graft can fail, and you can get such patients with, I saw lots of them, with graft fails in a few months after surgery. And the second thing, that PLC injury should be repaired several anatomical consideration for this. But also I want to pay attention that if you will see the look on the medial and lateral pathological and anatomy approach. But today we're going to talk only about the deepest layer of these 3 compartments, and we'll talk about Lateral collateral ligament is a point proximal and posterior to the lateral condyle. It measures approximately 7 centimeters in length, and distal is the main attachment to the lateral basal aspect of the fibular head as the conjoined tendon, which is forms with the biceps femoris tendon approximately 1 centimeter to insertion. So always remember that I think that all of you see such cases in your daily practice. So going next, normal anatomy of the biceps tendon, I won't stop on it. You should always just remember that the biceps uh, you should always look in the structure, because if you will not mention it and if surgeons will miss this, this can have a dramatic prognosis for the patient, reconstructive surgery of his cruciate ligaments. So here are the places where the body inserts, here is the place of a tendon insertion, and here you can see the relation between the lateral femoral condyle. So here is one more. There are two supporting structures which are holding the tendon or muscular tendon. The body of the popliteus and the injuries of the popliteus muscular tendon, usually they involve the muscle belly or a muscular tendinous junction of the popliteus. Here is one more example. This is partial. Scanners, this structure can be seen on majority of the coronal views, and this small tiny structure, it fixes the popliteus tendon and just reduces the amount of motion of popliteus. And this structure also you're gonna be very specific in telling this is partial tear or it's full tear. It's pretty small. All you need to do is just to evaluate it and tell if there is, for example, edema or a disruption if it's evident. About arcuate ligament, in fact, it's not a ligament, it's a capsular thickening. with abnormal signal intensity in the area of arcuate ligament and the capsule of the knee. Here is one more to go, and let's go next. So, what's the question? What should you do with all this anatomy? How could you report it? And you need the evaluation strategy for these cases. First of all, when you're dealing with the traumatic injury of the knee and the rupture of PCL or ACL, you should begin from identification of fibular collateral ligament, and I'm sure that all of you are doing this. The second thing, look on the biceps tendon and look to the tear or evaluate all of them. And the last thing, try to find arcuate ligament and popliteofibular ligament and look for the sprained tear or any abnormal signal in this area. And the last thing about grading. Grading, which I mentioned before and which is based on the functional tests. It's used by surgeons, yes, but you shouldn't use it in your daily practice and report it. All you need to do is just always mention ACL and PCL injury, cruciate ligament injury. The second thing, you should mention the primary lateral supporting structures, such as fibular collateral ligament, biceps tendon, popliteus tendon, or iliotibial band also, but it's not included in a posterolateral corner. And the secondary lateral supporting structures, such as popliteofibular ligament, arcuate ligament, meniscopopliteal fascicles, this won't be the big problem if your primary stabilizing structures are normal and there are going to be some abnormal signal in the secondary lateral supporting structures. This will not act or change the management tactics of this patient healing. And always report in your knee report that PLC structures are normal or abnormal. If even they are normal, just tell about in your report. And just a few more cases. There's a 27 years old male with a motorcycling accident. You see the full thickness avulsion. On MRI. Don't try to use staging and grading system because it's often difficult and not necessary. Just mention in the report what you see: edema, disruption, thickening, fluids surrounding posterolateral corner structures, and etc. And presence or absence of posterolateral corner injury will affect the treatment plan. Always remember about this. And always mention PLC in your reports when cruciate ligaments are injured, even if PLC is normal. These are Thanks for your attention.